And now we're going to talk a little bit about arthritis. Arthritis is defined as inflammation of a joint. There are three types that we're going to be discussing in this course: osteoarthritis, rheumatoid arthritis, and gout. So let's talk about osteoarthritis first. Osteoarthritis also is known as degenerative joint disease. It has an insidious onset, and this means that it gradually worsens over time, and it is the most common form of arthritis. It can be idiopathic, meaning we're not really sure what's caused the arthritis, and it can be secondary to some other disease. So for example, secondary cause, certainly it's not a disease to be older, but aging is a secondary causative factor for osteoarthritis. Genetics can also play a role, meaning that you have a family history of osteoarthritis, and other members of the family develop it as well. Another secondary cause can be obesity. So if you are overweight, you're putting increased pressure on the joints, and if you don't have the muscle strength to keep that joint stable, we could be exacerbating osteoarthritis by being overweight. Also overuse. So for example, sports injuries, football, soccer, high impact sports can cause osteoarthritis over time. And occupations as well. Occupations requiring frequent kneeling, stooping, such as painting, have a higher incidence of osteoarthritis. Menopause can be a causative factor due to decreased levels of estrogen. There are estrogen receptors on our bones, and so there have been some indications that menopause can increase our risk of osteoarthritis. So what's the pathophysiology behind the disease process? Well, we talked about cartilage being a natural shock absorber. And it cushions the ends of our bones, and it reduces friction in our healthy joints. Well, in the case of osteoarthritis, our cartilage begins to wear down, and the bone gets rougher. Okay, so here we see a picture of a normal hip joint. We see a nice, smooth, articular surface. And then over on the other side, we see decreased joint space, and we see worn cartilage. Okay, and what happens is this cartilage becomes more vulnerable to wear and tear, and it becomes softer and less elastic. So earlier we talked about it being a firm, rubbery substance. And so now we're talking about, in the disease process of osteoarthritis, it's more vulnerable to wear and tear. It becomes softer and less elastic. So the repetitive use of the joint over time wears down the cartilage, and the new cartilage being formed cannot be produced fast enough to balance out the loss. So deterioration of cartilage causes the bone to rub against bone, and this can cause pain and reduce range of motion. So joint pain is one of the symptoms of osteoarthritis, and so is stiffness. Patients can complain of stiffness, especially in the morning. And crepitus is another sign. There may be a loose cartilage in the joint causing a grating sensation or a popping, crackling sound that can actually be felt when you put your hands over the joint and move the joint around. And also deformity of the bones in the joint can also occur. So here we see an example of crepitus. We see hypertrophy and spurring of the bone and erosion of the cartilage. Okay. Something else that happens in osteoarthritis, if you've ever seen the hands of a person with osteoarthritis, are the Heberden's and the Bouchard nodes. And these are, again, spaces in the joints, specifically in the hand, where they become hypertrophied, and the bone is deformed and it is enlarged, and it is painful. And so what do we want to do to help these folks? They refer to actually the Heberden's nodes as being more distal, and the Bouchard's nodes as being more proximal to the wrist. So what do we do to help our patients? We want to balance rest and activity. We do want to immobilize the joints sometimes if they're having pain, but again, we don't want to immobilize them for too long due to stiffness setting in. So it's important, they may need an assistive device like a cane or a walker or some crutches, and so we want to try and balance rest and activity. Heat therapy can be helpful when stiffness is a concern or a problem. In the morning, you may encourage someone to get up and take a hot shower if they have stiffness in the morning to maybe loosen up some of the joints. Cold therapy can be used to reduce inflammation and swelling. Weight reduction is definitely a treatment that we want to encourage for those who are obese with osteoarthritis. Diet can be one way to lose weight. Exercise can be another way. The nice thing about exercise is that we would probably prescribe something low impact for these folks. Swimming, walking, bicycling. I would consider yoga and massage to also be some forms of low impact treatments or exercise. The interesting thing is that training with light weights can actually help by strengthening the muscles that surround the joint. So strengthening these muscles around the joint may actually help better stability in the joint area and decrease pain and inflammation. Although there are medications, of course, that the physician will usually prescribe, may start with some over-the-counter preparations. So we have examples of anti-inflammatory medications like aspirin, ibuprofen, or acetaminophen. And then there are also supplements that you can use from the health food store, such as glucosamine. We're going to talk a little bit about that in a minute. So pain-relieving creams are another option. Aspercreme contains salicylic acid, which can help with pain relief and decrease joint inflammation right at the site, so that you would rub this lotion onto the knee joint, hopefully helping decrease some of the inflammation. The nutritional supplement I mentioned earlier, glucosamine, chondroitin sulfate, is essential for the formation of cartilage and synovial fluid. Some folks take this and swear by it. They say that it works great for them. It has helped their pain tremendously. Others say that it is not effective. Maybe something else works for you. So we need to find out whatever it is that's effective for that patient and encourage them to, stay with that treatment. The other thing that's important to consider is certain supplements, dietary supplements like chondroitin sulfate, it might take time for these therapies to work. So you might encourage the patient to give it some time if they've only been on it for a week or two, that maybe they need to give it some more time to really decide whether or not this is an effective treatment. Glucocorticoids like prednisone are another option. We can give these as an intra-articular injection. That means that we directly inject a needle into the joint space, and we put prednisone into the joint space to decrease inflammation. Patients may also take prednisone PO to keep the pain of their arthritis and inflammation down. Also IM injections as well. But the thing we need to consider about glucocorticoid therapy is that we would never stop the patient taking them without a tapering down process. Okay, so for example, if we get a patient that gets admitted to the hospital and they have been on long-term prednisone therapy, and they're made NPO for surgery, we really need to consider getting an IV form of the prednisone, and that's due to the fact that our adrenal cortex is responsible for secreting our glucocorticoids, and when we take exogenous sources of corticosteroids, then our adrenal gland will be suppressed. And so if we stop the prednisone altogether, they could have what is referred to as an Addisonian crisis, and we don't want that to happen to our patients. So make sure that if you get a patient admitted to the hospital that is on long-term steroid therapy for any reason, that we are either tapering down that steroid use, or if they are on IV, that we have an order to be giving those steroids via IV infusion. So when all else fails, when pain and mobility make normal functioning impossible, people become candidates for artificial or prosthetic joint implants. And we do this using a procedure called arthroplasty. So here we can see a total knee replacement in which total knee arthroplasty is indicated. This person in this comic strip here, this little picture shows us a new articular surface, right? So the two places where the bones meet, this is the knee joint, have been replaced with a prosthetic materials. All right, this can be referred to as TKA, total knee arthroplasty, or TKR, total knee replacement. If you have a patient with total knee replacement in the hospital, they will most likely have one of these machines, a continuous passive motion machine, post-surgical. And this machine is very helpful in passively exercising the joint that has just been fixed so that stiffness and scar tissue do not form. It's a device that's used to gently flex and extend the knee joint passively as the patient rests in bed. So it can be used after surgery to allow the knee joint to slowly move. It improves the motion following a knee replacement, and it can help eliminate stiffness. By placing the joint in a CPM soon after surgery, it has been shown that scar tissue will be less likely to develop. But what's wrong with this picture? We have a gentleman here on a CPM machine, and there's something wrong with this picture, and good for you if you guessed it. He needs to have the bed rails put up, especially on the side where the CPM machine is located. Okay, so you ever walk into a hospital room, the side rails should definitely be up. On all four side rails should be up on a patient in bed with the CPM machine. So CPM machines have different controllers, and the interesting thing is that the physician will order a certain level of flexion, maybe 0 to 30 degrees, maybe as much as 80 to 90 degrees, and these are the different devices that we, the nurse, usually it's the physical therapist, will program to get the patient the type of flexion and extension that the physician has ordered.